Hirschsprung's disease, the big megacolon down there. Chang and Yang, they have the death test of Chang and Yang, the original Siamese twins, which is kind of cool. They actually they had just a little bit of liver, really, that kept them together, and some cartilage. Probably in today's society, they probably could have separated them using a kitchen knife and some string. I mean, they really weren't. It really wasn't as bad as some of the other ones you see. And it's interesting because they were both married to sisters, not identical sisters, but the sisters. Had 22 children between the two of them. Lived on 2 different farms, so one day a week they lived, or 3 days a week they lived on one farm, 4 days the other, and they switched back and forth. And one of them was a drinker, and the other one wasn't. Got in a fist fight at one point. Yeah, exactly. And the one, they did have a plan. They had a plan that if one of them died, they had a doctor on call who was going to come and try to separate when that happened. And it happened so that the one died. I don't remember which one. The drinker died on a night where there was a blizzard. And when they called for to get the doctor, they sent him to go get the doctor. By the time he got back, the blizzard slowed him down too much, and the other one bled to death because his heart kept pumping blood and it kept circulating over to his brother. Not in huge quantities, but in some quantities. But it just never returned. So he just let him go. Interesting. There's also a really good example of something called fibrodysplasia ossificans progressiva, where soft tissue, when it was damaged, actually changed into bone. So this patient, there's 400 documented cases in the United States ever. And this guy is from the Philadelphia area, donated his body to the museum upon his death. There's actually one of the universities around here still does a lot of research with that disease. But you can see his skeleton really kind of twisted. A lot of the vertebrae have fused together. You can even see areas where there have been skeletal muscle that are sort of changing the bone. You still see, but it looks like large stripes. It's very neat. So anyway, if you have not yet been to the museum, you've got to check that out. Yes?
Some question. If somebody would have been to do a CPR on the dead brother, probably wouldn't have helped as much, right? Because
Correct.
It would have been an acidotic coming back, right?
It would have been. It probably wouldn't have been enough pressure. I mean, you really have to. Well,
like the returning blood would be.
I know the one brother's heart rate would probably be so low. His blood pressure would probably be so low. It would be tough enough just to keep his blood pressure up high enough to get circulating up to his brain. Trying to get on the brother to pump it to return, that would be tough. I would think that would be difficult. And there would definitely be a change in the pH. Because you're talking about it's still going to be going around delivering oxygen. It's still going to be picking up waste products. It's not going to be leaving. That's an interesting question.
I just thought about that.
You should have been there. I mean,
no, I don't want to be that guy.
Would have tried, right?
Yeah.
Why not? I would have tried. That's a good question. I wonder if anyone has ever posed that before.
Just a thought.
I'll have to think about the fluid dynamics there alone. Would be interesting, but that's cool. I think it would have been easier just to cut them out, separate them. That probably would have been the best bet. That's a good question. All right, now I completely lost my train of thought. Oh, go to the museum, it's fun. All right. I get a little kickback every time I say that. That's not true. Have you seen this before? Dividing the abdominal region in the abdominal pelvic surface into regions. There is going to be variation with this, of course, because first of all, not all men look like this. Their bodies are going to be shaped a little bit differently. Not all people look like that. And if people aren't walking around with a big tattoo screen, there's not some stencil that we place on top of them and spray this into place. Instead, this is just what is visualized when we look at the abdominal pelvic surface. And then why do we break it into parts like this? This way we can kind of give us a better idea of the area of the body that we're dealing with, and therefore the anatomy that goes with those areas. Very easily, in naming them, we start with the umbilical region. It is simple to name because this is where we found the umbilicus, the belly button. So that is easy enough. Over here, we have the right hypochondriac region. Now that confuses people Because when they hear of hypochondriac, they think of a person who just always thinks they're sick, always thinks something wrong with them, always wants to be tested. But if you look at the combining forms, the prefixes and the suffixes, we know that AC means pertaining to, the suffix AC means pertaining to. We know hypo means below, and chondro means
Your rib cage.
cartilage, actually. Constitutive rib, chondro is cartilage. So this is the area pertaining to below the cartilage, which is the cartilage coming from the ribs. So that actually makes sense. It makes more sense to call that the hypochondriac region. Now, why then is the person who's always sick a hypochondriac? Back in the days of the early Greece,
The breathing.
they believed that all of the things that happened in your body were based around the four humors. You know what the four humors are? Blood, phlegm, yellow bile, black bile. These are the fluids that kept your body healthy. And if there was a change in those fluids, well then that was the problem. You had to correct your humors. Which of course an easy way was to bleed. That's why they still did that into the, 1600s, 1700s, maybe even later in some places. Even today, I'm sure, in some places. So they believed that the four humors is what kept the body working. And of course, where do we find these humors, like phlegm and black bile and yellow bile and blood? We find a lot of that right at the liver, which is going to be just up underneath here. Below the diaphragm, stretching across, not that far, stretching across into the left hypochondriac region. If we trace the liver, we'd see it would end up something like this. So the reality is, if somebody asked me where the liver is located, I'd say it's in the right hypochondriac region for sure. It stretches into the epigastric region and all the way over into the left hypochondriac region a little bit. And people would argue, well, isn't it in the umbilical region? Because it comes down like right through here, maybe in the right lumbar. Well, again, this is not static. This is just something that is imagined, right? So one person can see this grid, can see this tic-tac-toe board one way, and somebody else could see it another, to where a little bit here and a little bit there would make the difference between whether or not the liver is considered part of that. So this is just a good representation. I never ask students if the liver is located in the umbilical region, because I'm going to get half the answers correct. Half the people are going to answer yes, some are going to answer no. Somebody else is going to say, we have no idea. So as long as everybody understands, it's mostly over here. Most of the liver. Also the bulk of the liver, because of course as the liver comes to the left side of the body, it tapers quite a bit. Now, we've effectively created a right side and a left side, which is nice. And we find this a lot in medicine. There's a lot of repetition in the human body, thankfully. That makes it that much easier. This is why we use terms like right or left. This is why we use terms like anterior and posterior, superior, inferior. And this gives us a really big clue. Because if I ordered a pizza and I asked the person to deliver it to my house, and I told them, please bring the pizza to the back door, how many doors must that house have minimum?
At least two.
It has to have at least 2 doors, right? Because I specified bring it to the back door. If there was only a back door, then there'd just be the door. I'd say bring the pizza to the door. Eventually they would find it, but there would only be one. So when you see things like this, make a note of that. When you hear somebody talking about a torn ACL, you know what this is? Anybody have any idea what an ACL is? Anterior cruciate ligament. We call it the anterior. Why?
The inside.
Well, it's in front. But there's a lot of things in front. There's only one patella in front. We don't say it's the anterior patella. We say it's the anterior cruciate ligament, which crosses over. Cruciate meaning cross. Because there must be one in the back. There must be some other direction to that. So when you see things like this, when you hear about the superior vena cava, that must mean there's an inferior. When you hear about gluteus maximus, there must be a gluteus minimus. So there's a lot of clues in medicine. You just got to pick up on them. Once you start hearing this terminology and understanding what they're really saying, it kind of makes sense. All right. We've created a right hypochondriac region, so there must be a left hypochondriac region, and there is. Below that, we have the right lumbar region, of course, where we see those vertebrae as well. And below that is the left, what do they have here, iliac? I prefer inguinal region, but you'll see both iliac and inguinal. I prefer to teach this as the right and left inguinal region. The reason for this is because later on, when we talk about the skeleton, we know the bone right here is called the ilium, I-L-I-U-M, and the round part right here, you can feel the iliac crest, right? So even if you never, I can't cut it up like that. Even if you never learned the word iliac, if somebody called that the iliac region, you'd be able to figure it out, right? So that's why I'd rather teach inguinal, and then you'll see iliac later on. But the nice thing is, with having a right and a left side, we've got umbilical region, and we've got these other 6. Now we have 7 of 9 of the regions named fairly easily. This area is said to be above the stomach. This area is said to be below the stomach. Epigastric, hypogastric, hypogastric. Now,
Doesn't the stomach sit majorly in the epigastric?
it does. Well, but again, look at a different grid. Now, here's the thing. You may have seen this before. You may have seen this image before. You may have even understood and memorized all these areas before, all these regions before. One thing you might not have noticed, though, when you went to the doctor or somebody you cared about, you took to the doctor, and the doctor had the patient lying down, what you might not have noticed, but you will now every single time, is when the doctor's palpating the abdomen, the doctor starts someplace like the left inguinal region, and then moves into the left lumbar region, and then left hypochondriac, and then epigastric, and then umbilical, and then hypogastric, and et cetera, et cetera. They follow this pattern. And the reason, because we were all taught this exact same way. We all follow that same 9-region pattern. Or we'll start from this side, it sort of depends on the doctor. Move away or move towards themselves. But you probably never, when you saw them doing this, you probably never pictured the grid on the patient. But now you will. And of course, it's done like that because we know while we're palpating, what else are we doing? We're looking at the patient's face. For what?
Guarding.
Some sort of pain response. Yelling at us, spitting, turning blue, something bad, something good, ticklish. All right. Oh, we're going to go then to the easier. I'm not going to do any of that. We're going to do the quadrants. To make it a little simpler, if we just want to divide the abdominal pelvic surface into 4 areas, it's very, very simple. All you do is you find the umbilicus, you draw a vertical line through the umbilicus, a perpendicular line at that point as well, and we've created a right side, a left side, an upper part, and a lower part, and because there's 1, 2, 3, 4, then we call them quadrants. So now we have a right upper quadrant, a left upper quadrant, a right lower quadrant, a left lower quadrant. Nice thing about this image is you can see the liver a little bit more. Sitting over there. So clearly, the liver is located in the left upper quadrant, mostly, but also in the right upper quadrant. But the bulk of the liver is really over here. So if you're going to require a needle biopsy of the liver, where would you stick? You would stick in the right upper quadrant, right? Could you hit it on the left upper quadrant? You could, but you could also miss. It's a lot easier that way. Notice the umbilicus. This is kind of an important thing to realize here. Because when you look at this guy over here, and you don't have that grid, where's the belly button? Yeah, you look up there, and you look over there, you look up there, you look over there, up there, over there, and you say, well, it's going to be about here. Yep, it's going to be about there. Which means when you see this bulging little belly button, somebody talks about the umbilical hernia, what is that that's protruding up through that region? It's a little bit of small intestine that can be poking up through that region in some cases, right? So, again, quickly, you can see where some of these organs are located. Nice basic breakdown. All right. A lot of people do have confusions about hernias, though. They think a hernia only applies to the one that's in the groin, or only applies to the one that's around the heart, going into the thoracic cavity. A hernia is just a very general term. What happens during a hernia is when part of an organ moves into an area that it doesn't belong. We've just learned that the body is sort of sectioned off into these different compartments, these different cavities. When part of an organ moves from the cavity where it's supposed to be to a place where it's not supposed to be, we call that a hernia. And now, where's the cavity up here? Has it somewhere? Oh, okay. Hernia is a tear in the muscle wall. Not really. It doesn't have to be a tear. It can be a looseness. You know, we have areas of the body that were open at one point, and then we're supposed to close. Or at least we're supposed to close somewhat. And if those areas didn't close enough, or if the strength around them was jeopardized in some way, or there was some sort of insult that caused that area not to be closed, then we can have part of an organ move from an area where it does belong to an area where it does not belong. In some cases, it'll move back. That's what we call a rolling hernia, or a reducible hernia. You can push it back. In some cases, it gets stuck. And we call that an incarcerated hernia. And it's really tight.
Strangulated.
Because that's exactly what's happening to the blood supply to all that tissue, all those cells, which is going to cause problems. So if we have something like, oh, look at it. Oh, I lost it completely now. Okay. If we have something like this direct inguinal hernia, and it is really, really tight, and blood supply is getting cut off to that part of the small intestines, we are going to see irreversible cell death occur in, I don't know, how long do you think that would take? Irreversible cell death if you cut off blood supply to that tissue.
20 minutes?
I would say 6 hours. That's a pretty good guess. Good number. Yeah, they don't teach you that in medical school. They teach you in surgery that if that part of the intestine didn't get blood supply, then they would have irreversible cell death in 6 hours. And then you learn in the emergency room, well, you know what, you better get that totally attached. Or otherwise you're going to have irreversible cell death in about 6 hours. Or, you know, if that person loses blood flow to the brain, we're going to have irreversible cell death in 20 minutes. And it's not until you get the big picture and you step back and go, that's 6 hours for every other part of the body, except the brain is part of it. It kind of makes sense. And the nice thing is it makes it easy. You know? You ever heard of, what is that medication called? It's very obscure. You guys have probably never heard of it. It's called Viagra. This medication is going to allow blood flow to a part of the male body. And what it does is it causes the distension to occur, the increase in blood flow to the penis, of course, and that spongy tissue. Well, that distension that follows is actually going to be compressing blood supply, but not from the outside on it. It's actually going to be compressing blood supply from the inside out. Because remember, of course, the skin's covered in penis, and the penis, of course, the penis is covered in skin, and of course, the skin needs blood, and of course, it's going to have blood vessels going to it. And so, when that tissue gets engorged like this, it's going to put pressure on those blood vessels. So it's actually going to decrease blood supply to the surface of the skin. Now, for a short period of time, that's no big deal. But if that distension lasts for a long time, we're going to see irreversible cell death, which means necrosis. And what do we do to necrotic tissue?
Cut it off.
We cut it away. Man, that's not good. That's not a good day at all. So if you notice in the commercials,
They say 4
they
hours.
tell those people, if an erection lasts longer than
4 hours.
4 hours, go to the emergency department. Oh, listen to this.
You
Ladies
got
and
2
gentlemen,
left.
what is the average wait time in an emergency department in the United States?
2 hours.
Where do you think they come up with these numbers from? This isn't just somebody saying, let's just say 4 hours out of the blue, and let's get this over with so we can go home and have lunch. This is physiology. That's why they come up with numbers like that. I think I'm making this stuff up, man. It's the truth, I'm telling you. You're going to hear all those other things. They're going to talk about cell death in 4 minutes, cell death in 17 minutes, or some obscure number. Well, we're going to see cells start to die. Irreversible. Gets to that point where you can't bring it back. That's 20 minutes. Big difference. So, if we have a patient who has a hernia like this, and it starts to tighten around, or another condition where the intestines twist, we've heard of this, malrotation, volvulus, that's bad, that's an emergency. You know, we're not going to look at our calendar to see when the emergency department or the surgical department is open. We're gonna get this person in and come up, usually a younger person, or dog. Actually, some breeds of dogs, so I think they're bigger breeds. All right,
Full stomach rotates.
yes.
What's a sign or something like that?
Portion.
In a dog.
Or a person?
Screaming, pain, agony, bloating, yeah.
Trust me, it hurts.
That's
It
not
happened to
hurts.
me.
Did it? Yeah, that's bad.
Well, I'm glad you got better.
Yeah, we are.
They moved your surgery up real quick.
Yeah.
Couple
Yes,
weeks.
yes, they do.
Oh, yeah, come in now.
They don't mess around with that. Because if that tissue dies, what loves dead tissue but bacteria? Bacteria loves dead tissue. So it goes from that dead tissue to infection very, very quickly. And then that infection into the blood very, very quickly. And this is called, and I know you know this, sepsis, septicemia. Right. Okay. Umbilical hernia like this little baby has, not often a big deal. Most umbilical hernias are cosmetic. A lot of people go their whole lives with it, not a big deal at all. Sometimes you sew a little patch right in there. Easy peasy. Ah, right. Some of the other little regions, we've talked about some of these already, which is the external, axillary, brachial, and cubital. Which is what? The elbow bend area. I think everybody's familiar with that. Antebrachial. Might throw an IV. Carpal, we've heard of this. Digital caudal, gluteal. Plantar. Plantar, of course, bottom of the knee, down by the plant. This is just memorization, right? Further knowledge of the anatomical landmarks is important. I'm showing an image like this to my class earlier today, and they were medical assistant. There were paramedics and some medical assistants and some more medics. And I put a picture like this picture actually. I put this picture up, and I said, "Is this person going to live?"
Depends. Depends on-
Really? No answer? What do you think? Is this person going to live? This is a gunshot wound to the chest.
Depends on where it went.
Depends on where it went. Gunshot wound, not gunshots to the chest. Gunshot wound. Why is this person going to live?
I'm not sure.
Okay. Yes.
It's superficial because the entrance is the lower one.
see an
and the
entrance
upper
wound.
one, and you see the exit.
And you
wound.
see the exit. And you
Went
see the
across the
exit wound.
skin.
Well, it goes this way. You see, you're looking at this, you just automatically assume that the person was standing right in front of them, shot it, went in just like this. Stand back, take a better look at the picture. You can clearly see an exit wound here. Clearly see the entrance wound here. That's superficial. I'm going to say, yeah, he's probably going to live. You could probably stop the bleeding or control it really well, right? Nerve damage, muscle damage. As long as there's no bullet fragments broke off and moved into the thoracic cavity.
But then there's
Otherwise,
a hospital-acquired illness.
I'm sorry?
Then there's a hospital-acquired illness because they went through an ER.
If you want to get sick, go to the hospital. That's where they keep the germs, right? That's where all the sick people are. You get things like the MRSA, methicillin-resistant Staphylococcus aureus, Clostridium difficile. You've heard of this, but you call it C. diff. You know why you call it C. diff? Because nobody wants to say Clostridium difficile, because that's a big couple of words. C. diff. 95% of the people who have Clostridium difficile are hospitalized, or at least in a facility. So you don't usually see it outside. MRSA you see a lot in hospitals as well. Methicillin-resistant Staphylococcus aureus. Have you heard of Staphylococcus aureus? This is a common bacteria. You know, infectious disease. Staphylococcus aureus. This is a common bacteria. This bacteria is so common. It's on your pen. It's on your notepad. It's on your hair. It's in your mouth. It's in your nose. Last time you went, you probably breathed some in. That's how common this is. Because of course, bacteria are very light, right? Going through the air. So. Staphylococcus most of the time doesn't cause us much of a problem. If we get it in big doses, it can cause an infection. So we get a big dose in the food that we eat, we end up with acute food poisoning, acute gastritis. You start throwing up. The books will tell you 2 to 8 hours. I'm telling you, you can see it as early as 1 hour after ingesting the stuff, up to about 8 hours afterwards. And these people will throw up every hour on the hour. You can almost set your watch by it. And that will last for 6 to 8 hours, maybe throw some diarrhea in at the end just for kids. But after that, they'll be fine. And they'll feel like they're beaten up with a baseball bat the next day, but we don't really do much for them. Give them fluids. That's about it. Because the reality is, bacteria didn't get very far. Didn't really create any big problems. But if it gets inside of a wound, creates those little staph infections, and it's a little bit more of a problem. If it gets itself in there, starts growing and growing and growing, create a problem. Well, the thing about MRSA, the methicillin-resistant Staphylococcus aureus, this is a bacteria that has learned how we kill it. And the reason this happens is because of what you did
Don't want to take the antibiotics.
when you were given that bottle of antibiotics by your doctor because of your sinus infection, because of something else, and the doctor said, take all of this until it's gone. 5 days into that doxycycline, after choking it down, trying not to puke, feeling miserable, you start feeling better otherwise, the other stuff's gone, you say, I'm done with this. You go home, you still have 3 pills left in there. Problem is, all that bacteria is not necessarily gone, not necessarily. Which means, now it's getting small amounts of that antibiotic. Not enough to kill it, not enough to stop it from replicating, enough for it to say, now I understand it. So if I make a little change here, I can avoid any problems with it over there. And then we end up with drug, and it is a little bit harder, it's a little bit more virulent. So he's a little nasty bugger. We see this a lot in hospitals because people get antibiotics switched on and off. A lot of people coming in and out in different varying degrees of infection, varying degrees of antibiotic resistance they're carrying around with them. The nosocomial infection, right? This is the infection that a person gets in a hospital setting. They came in without this infection, and they get it while they're there. And I always ask people, well, how did they get that? How did they get that illness? How did they get that infection? Who gave it to them?
They're caretakers. They're caretakers and nurses, doctors.
Nurses, doctors, get out. I'm just kidding. Nurses, doctors. You've never seen a doctor wash their hands? Oh man, come on. Absolutely, you wash your hands. People are filthy. So yeah, you wash your hands, you glove your hands, use that hand sanitizer. Go behind any nurse's station, they have a moisturizer this big, because all they do all day is wash their hands. No, do you know what the problem is? The problem is that person who comes in to visit Uncle Joe and goes up to the nurse's station and says, excuse me, where's Uncle Joe? And she says, oh, he's down the hall on the right. Thank you very much. And walks down the hall, and they're walking down, and they'll hold on to the handrail all the way down. They'll go up to Uncle Joe, and they'll tuck him in, they'll wipe that stuff away from his mouth, and they'll say, oh, you look great, Uncle Joe. I'll be back in a little bit, and then they're down in the cafeteria. And they walk out of the room, and they got some Uncle Joe's germs on them. And they walk down, they hold on to the handrail, and they go, oh, it's from the nurse's station, because they don't know where to go. And they go, excuse me, where's the cafeteria? And they leave some Uncle Joe's germs behind. And then they walk down the hall, hit the elevator button, go down to the cafeteria, pull out a chair, get a tray, take a spork. But they don't need 2, so they put 1 back. Pay for their meal, get change back. This whole time they're leaving a little bit of Uncle Joe's germs around. And then somebody comes up to see Aunt Jane. Excuse me, where's Aunt Jane's room? And they pick up some of Uncle Joe's stuff and walk down and see Aunt Jane. And then have Aunt Jane's stuff on their hands and comes back and says, pardon me, where's the cafeteria? I'm starving. Because my stomach hurts. Meanwhile, they put down some of Aunt Jane's, picked up some of Uncle John's. Imagine this happening all day long. And then how many times we touch our face throughout the day? A couple thousand. There's some more. Let's get it over with all at once.
They're all hypochondriacs.
Imagine this happening all day long. Watch a calendar somewhere at a Wawa. Watch how many people put their hands on it. Were they just cleaning up after their dog? Maybe they were just cleaning up after their child's diaper that had diarrhea. Maybe they were working out back with the sheep and the soil, picking up some anthrax on their fingertips. Who knows? But now it's on the counter, and as soon as you touch that, now it's on your hand. Something to think about. Stop touching your face. You know, I always tell people, don't be afraid to ask questions. I just ask that you don't ask me questions that are personal to you, right? I don't want you to come to me and say, look, I have this rash and such and such. Anything that I say is not medical advice. It is my opinion, and has to be taken as such. It does not trump your family physician, et cetera, et cetera. That's for the lawyers. Get that, okay, good. I don't want to get sued.
We're gonna hear that every single time.
Well, now it's on tape. You'll see this video. Footage of this. I'm sorry?
What about the chiropractor?
They're wonderful people. Lawyers are great. We love our lawyers. They're fantastic. Saints is what they are. It's the people who are spreading that suffering. And then some of those patients have their family come in with their children. And children, they're just bags of pinworms and pink eye, spreading this stuff everywhere. They touch everything, and they never wash their hands. You know about pinworms, right? Yes, no? Oh, this is a great parasite. This is a parasite that actually lives in the rectum.
It comes out at night.
Comes out at night.
Makes them itch.
No, lays eggs around the perianal area. And those eggs stick to that perianal area. The stickiness that adheres those eggs to the perianal area
Makes them itchy.
causes an irritation, which causes the area to itch. And what do children do when their butt itches? They scratch it. And they end up with all these little eggs stuck on their fingertips. And then they come over to you and your bowl of popcorn and stick their hand in like this. And now they've deposited some of those eggs into your popcorn. And they're going to redeposit some into themselves. That's why if somebody has pinworms, Enterobius vermicularis is the name. That's what they call them, pinworms. That's why if somebody has these, who do we treat? If a kid in the family
The
has
whole
it,
family.
treat everybody.
How common is that? I've never heard of it.
Very.
4 million cases in
It's
the United
very
States a year.
common.
There's about 40 million cases. Enterobius vermicularis, right?
Yeah.
Oh, then since you're on there, it will tell you how we test for this. It is called the Scotch tape test.
On their butt.
Yes, that's the one.
That's
I
it.
saw your eyes go up. Oh, yeah. Early morning hours before the child's awake, you go into the bedroom, you spread their butt cheeks. You get a piece of Scotch tape, you spread it over the perianal area, you tear it off, you put it on a little glass slide that we provide for you, you stick it on there, bring it back to the office. Looking
There's
for
eggs.
O&P, ovine parasites, looking for eggs, exactly. And that's its name, it's called the Scotch tape test.
A lot of kids in daycares get them.